My name is Dr. David Newell, and I'm at the Seattle Neuroscience Institute in Seattle, Washington. I'd like to give a short slide presentation to accompany the chapter on Diagnostic and Therapeutic Neurosonology. I'd like to thank my co-authors who have contributed to this chapter and this work, Dr. Stephen Monteith and Dr. Andrei Alexandrov. I want to start by talking about the history of ultrasound in relation to neurosurgical applications. In 1842, Christian Doppler described the Doppler effect when observing stars and taking into account a color shift in the light from stars, whether an object was moving away from or toward an observer, which described the Doppler effect. This can be applied to sound also, which is a wave, and sound can be heard to have a higher pitch as it's being reflected off an object that's coming toward the observer, and then a lower pitch as something is going away from the observer, and the speed of the movement of that object versus the observer can be calculated from the Doppler equation. Now, the piezoelectric effect is also important to understand, and this was discovered when it was appreciated that a crystal, if an electric current was passed across a crystal, it would generate a vibration and a frequency. And conversely, if sound came into contact with a crystal, it would generate an electric current, which could be measured by an instrument. So basically, Doppler instruments are used to take electricity, run them across a ceramic crystal, which vibrates and then gives off sound, which is used to measure the blood flow. So instrumentation was developed to measure blood flow in veins and arteries based on this piezoelectric effect. And most Doppler probes have artificial materials of ceramic that are used to generate the sound in the ultrasound frequency range. Sotomore and Kaneko in 1959 developed this technology, leading to peripheral vessel ultrasound. Quantitation of carotid stenosis with continuous wave Doppler was reported by Spencer and Reed in Seattle in 1979. And then the imaging characteristics, the B-mode ultrasound was added to this, which imaged tissue, and the current carotid duplex or duplex scans were made by combining the imaging with the Doppler ultrasound blood flow velocity measurements, and this is in common use in vascular medicine and neurosurgery today. Dorman and Rubin reported the first use of B-mode ultrasound for neurosurgical applications in 1981 by using a tissue imaging type B-mode probe to locate subcortical lesions in the brain and spinal cord, and describe the use of localization and characterization of intraoperative findings during cranial operations, which was a very useful application and is still used today. Transcranial Doppler ultrasound was introduced by Dr. Rooney Oslett in 1981 and first published in 1982 in the Journal of Neurosurgery, describing a method to record blood flow from the basal intracranial arteries, and opened up the whole new field of transcranial Doppler ultrasound for diagnostic purposes. Sonothrombolysis of clots in intracranial arteries in acute stroke was first reported by one of my co-authors, Dr. Andrei Alexandrov, in 2000, and described a dramatic clinical improvement in a patient that he was monitoring that had received TPA for the characteristics of the recanalization. He observed that the artery suddenly opened and the patient developed a rapid clinical improvement, which coincided with the lysis of the clot. He then went on to study a larger group of patients that were treated with TPA with and without ultrasound focused on their artery, and I'll discuss that later. MRI-guided focused ultrasound prototypes were originally reported by Heinen in 2004, and the instrumentation has been subsequently refined and developed and put into widespread use over the last 10 years, and machines have been developed to operate within an MRI scan that can select a site for a lesion, and the ultrasound can generate a heat lesion which can be placed at multiple locations in the brain for a variety of purposes, which we'll talk about toward the end of the talk. Now, this is the original artery, or the original article describing the Doppler flow meter by Satamura and Kaneko in 1959. If you look in the lower right-hand portion of the picture, they're examining the patient's neck with a probe to detect flow in the carotid artery. They were actually originally trying to measure cerebral blood flow, but they concluded that the skull was too much of a barrier to permit useful examination, so they focused on the carotid artery in the neck, and the whole field of peripheral vascular ultrasound developed from these concepts. In the upper right, the principle is shown here. The RX is indicating a receiver or a transmitter of the ultrasound. It's aimed toward flowing blood in a vessel, and the speed of the velocity of the flowing blood, shown in the center with the letter V, indicates the blood shifting in position over time, and the blood flow speed determines the shift in frequency that's reflected back to the probe of the ultrasound that's being initially transmitted. So this is called the Doppler shift, and can be used according to the Doppler formula to calculate the velocity of the flowing blood. So this is the whole principle behind measuring velocity of flow in different arteries through a Doppler probe. So this has led to the development of carotid duplex, which is a combination of B-mode ultrasound therapy, which shows the tissue planes in different densities, so that you can make out the anatomic structures, and the color flow, which is transposed on any increased velocity that's detected due to flowing blood, and then the Doppler ultrasound profile is down below, which shows the velocity of the blood in that particular area. So on the top frame, this is a normal carotid artery bifurcation, with the external carotid being located superiorly, the internal carotid artery below, and the common carotid artery to the right. And this is the area of the internal carotid origin where most stenosis from atherosclerosis is seen, as illustrated in the picture in the lower right-hand corner. The peak systolic velocity is 59 centimeters per second in the velocity profile in the upper frame at the lower portion, which indicates a normal velocity. Down below, with severe stenosis, you can see that the color flow signal is interrupted. You can see the anatomical narrowing of the artery, and also the increased velocity, peak systolic velocity profile of 334 centimeters per second down below, showing high velocities through a severe degree of stenosis, which is typically seen in patients who are candidates for carotid endarterectomy or stenting, or possibly medical therapy, depending on the degree of their carotid stenosis. The next slide illustrates the principle of transcranial Doppler ultrasound. And on the upper left in frame A, this is a typical recording from placing a probe on gel just in front of the ear in the transtemporal window, where the bone is quite thin and is devoid of a lot of cancellous bone, and the inner and outer tables can come together in the thin portion of the temporal bone and allow the ultrasound to penetrate easily and be reflected off the flowing blood in the middle cerebral artery. The spectral tracing on the lower left shows the spectral outline and the typical spectral tracing at about 50 to 60 centimeters per second, showing quite a high flow in diastole, which is typical of the flow in the intracranial vessels with a low vascular resistance. The other routes for examination are through the eye, where the ophthalmic artery and the carotid siphon can be identified and examined, and also through the foramen magnum, through the transforaminal window, where the two vertebral arteries and the basilar artery can be examined for their flow velocity. It's important to note when examining an artery with Doppler ultrasound that the measured velocity will depend on the angle between the stream of ultrasound and the flowing blood. So if there's a zero angle that transmits the ultrasound and then reflects it back to the probe, 100% of the measured velocity of the true velocity will be reflected in the measured velocity. However, as seen in the second slide, if there's an angle of 30 degrees, not all of the true velocity will be appreciated as measured velocity, and that will change as the cosine of the angle from examination changes. So for example, at a 30-degree angle, only 87% of the true velocity will be measured, even though the flows are the same. And at an angle of 60 degrees, 50% of the true velocity will be appreciated as measured velocity. At a 90-degree angle off the vessel, none of the moving blood is detected at this point, and the velocity profile will drop to 0. So it's important to realize that the velocities can be affected by the angle of a measurement from the vessel. One of the other important features of transcranial Doppler is that it can detect very high vascular resistance that can be seen with increased intracranial pressure and severe vasoconstriction, which can occur in a variety of situations. So as indicated below, as the cerebral perfusion pressure starts to decrease, the velocity profile will reflect a decreasing diastolic velocity until this actually crosses the baseline, and in diastole the flow will actually reverse due to the back pressure. So at late phases of high resistance, biphasic flow or oscillating flow will be seen because the blood flow distally in the regulating vessels is not flowing very well, and the measurement is taking place at the conducting vessels. So in the final stages of this oscillating flow, it will just be a to and fro movement of the blood in the vessel being examined in systole and diastole of the cardiac cycle, and then all flow will cease as the circulation shuts down. The Doppler ultrasound has been shown to be very useful in predicting cerebral circulatory arrest, which is often seen in brain death, so it's a confirmatory test in patients that are suspected of having brain death. This is a illustration of a patient with cerebral vasospasm with subarachnoid hemorrhage, and as you can see, the upper left shows the probe focusing on the middle cerebral artery on the left, which is narrowed compared to the right side, and the velocity profile, instead of being the typical 50 to 60 centimeters per second, is noted to be 215 centimeters per second, which indicates a high acceleration of the blood flow through that stenosis. And the RCBF drawing here shows a decrease in blood flow in that middle cerebral artery when it can no longer be compensated for. This is a hemodynamic simulator illustrating a case of cerebral vasospasm, initially showing normal velocities in the middle cerebral artery, and as the artery starts to become more narrowed with cerebral vasospasm, the velocity is increased initially, and the blood flow indicated by the RCBF frame in the center lower portion is unchanged. As the velocity becomes higher, and the vasospasm becomes more severe and then critical, the RCBF is reduced from the inability of the cerebral circulation to compensate for the severe narrowing. And at the point where it's terminal, the vessel begins to shut down, and the velocity drops toward the end from more and more severe stenosis. This slide illustrates the concept of recording for cerebral emboli in the intracranial circulation. The middle cerebral artery signal is being recorded in this videotape, and small formed element emboli are seen in the spectral tracing. These can indicate emboli that are shed from more proximal location, including the heart or the carotid artery, or dissection or stenosis proximal to the recording site. Active emboli often can mean that there is a diseased artery and platelets are actively aggregating and forming and being shed upstream. So the significance of cerebral emboli in brain disease are illustrated by a couple of points here. It's noted that after carotid endarterectomy, a rapidly increasing number of emboli per hour and then greater than 50 an hour correlates with ischemic events in the post-carotid endarterectomy patients. And it's been shown that vigorous antiplatelet therapy can reduce these emboli and possibly reduce the chances of distal stroke or postoperative thrombosis. Emboli in asymptomatic carotid stenosis patients predicts a higher stroke risk for a given degree of stenosis, and this has been the subject of the ACES study that was run by Hugh Marcus in London, showing that these patients had a dramatically higher risk of subsequent stroke if followed prospectively when they had a large number of asymptomatic emboli that were constantly being emanated from a given degree of carotid stenosis. It can be, the emboli detection test can also be used to test for patients with a patent foramen ovale and patients with stroke of unknown origin, indicating that the right to left circulation is present. So agitated saline is injected in a peripheral vein while transcranial Doppler is being recorded, and if the air bubbles that create these embolic signals show up immediately after injection, it indicates that there's crossover. Normally they get filtered by the lung. However, if there's a crossover between the right and the left circulation from either a patent foramen ovale or a peripheral fistula in the lung or other organs, then they can appear in the brain during injection, and this is a positive test for right to left circulation. And these may be these findings may be used to select patients who could be candidates for foramen ovale closure, the ones that have had strokes of unknown origin and are at risk for further stroke in the future. Emboli are also seen in the middle cerebral artery in carotid dissection from spontaneous or traumatic origin, and in traumatic origin cases are associated with stroke versus the patients who didn't have emboli that had a carotid dissection, so that can be a useful finding. Now this is a composite illustration showing the phenomenon of sonothrombolysis, which indicates that the blood clots being interrupted with the combination of TPA or thrombolysins and ultrasound together. It's been shown experimentally that if you add ultrasound to a blood clot in a dish that's being bathed in TPA, that the rate of lysis is approximately 3 times faster when the ultrasound is applied. And the mechanism is that the ultrasound causes an effect called acoustical streaming that pushes the TPA through the interstices of the clot and helps degrade the fibrin and cause the clot lysis. So this has been shown to be useful in patients that have acute stroke, and if you apply the ultrasound onto the artery when they're being administered intravenous TPA, the rate of recanalization of the artery that's blocked is considerably higher. This was demonstrated by one of my co-authors, Dr. Alexandrov, in an article that was published in the New England Journal of Medicine in 2004, where prospectively patients that were being treated with TPA intravenously for acute stroke were compared with ultrasound treated versus control patients. And as you can see, TPA bolus is given, and after 2 hours in the control patients that were given only TPA alone, there's just over 10% recanalization, sustained complete recanalization of the artery in 120 minutes, whereas the target patients that were given TPA plus the ultrasound on their artery for 2 hours, the recanalization rate was up in the 30 to 40% range. So this has led to subsequent trials that are being done to look at the rate of recanalization and clinical outcome in patients prior to arrival at a center that can do clot retrieval. If there's an extended time window, it could possibly be used, if successful, to open up more arteries in patients that are getting initial stroke treatment prior to intra-arterial treatment. One of the other possible applications of sonothrombolysis includes lysis of clot in the ventricle and in the brain. We performed a study with Dr. Dan Hanley using the CLEAR and the MISTY protocols, which are protocols to use stereotactically placed ventricular catheters in either an intracerebral or intraventricular hemorrhage and administer small doses of TPA on an 8-hour interval to try to facilitate the lysis of clot and reduce the clot burden in the brain. We did a small safety study where we used the same protocol but added a micro-ultrasound catheter, and showed in this small group of patients that there appeared to be safe, and there was enhanced lysis, and the clot removal normally was accomplished in 24 hours compared to the amount of clot removal that usually took 2 to 3 days with the TPA alone. The other exciting use of ultrasound in the brain more recently has been the development of MRI-guided focused ultrasound, where multiple beams of ultrasound in a similar configuration as gamma knife are focused on a central point in the brain in a patient in an MRI scanner in a Lexel frame, where a water bath bladder is placed over the head to avoid any air in the path of the ultrasound, and all the beams converge in a central area in the brain to create a small heat lesion, and these heat lesions can be placed in different functional targets similar to radiofrequency lesions in the past that were placed with radiofrequency probes through burr holes and stereotactic frames. So one of the conditions that has been most intensively studied is essential tremor, where a heat lesion can be placed in the ventro-intermedial nucleus of the thalamus to affect essential tremor. And this drawing shows an example of a patient before and after engaging in a drawing task showing the effect of the lesion on the tremor. This slide shows below the target in the thalamus, and on MRI on the right shows a permanent lesion that's created in the desired location. Initially, a series of patients that were treated were followed for 1 year, and they showed a durable result. There's been a recent publication extending this follow-up to 3 years, showing that there remains a durable effect of the treatment over time. More recently, the observations have been extended to using MRI-guided focused ultrasound for Parkinson's tremor, treating the GPI and other targets, and a recent publication showed that in a randomized prospective study that Parkinson's tremor was effectively treated with focused ultrasound. One of the other more Recent targets has been to treat intracranial tumors. If focused ultrasound is delivered in lower doses that do not cause a heat lesion in the brain to the point where the tissue becomes necrotic, a sublethal dose can be delivered that interrupts the blood-brain barrier and may facilitate chemotherapy delivery to the tumor and peritumoral area by interrupting the blood-brain barrier and by allowing chemotherapeutic agents to pass more freely into a targeted region. Also, if the lesion is or if the intensity of the ultrasound is increased to the point where it necroses tissue, it can be used to treat deep tumors that have already failed resection and radiation and or radiosurgery, possibly controlling the tumor for a longer period of time. In conclusion, diagnostic ultrasound has become an important and useful tool in neurosurgery for tissue assessment and vascular assessment. Ultrasound plays an important role in cerebrovascular neurosurgery to assess blood flow abnormalities before, during, and after neurosurgical procedures, and has been especially useful to non-invasively detect and monitor vasospasm in patients with subarachnoid hemorrhage. More recently, ultrasound has proven to have unique therapeutic applications, including sonothrombolysis and focused ultrasound to treat a variety of brain disorders, and this field is developing rapidly to include a number of future applications. Thank you for your attention.